Thank you and good afternoon. So Simran, do you want me to share my screen versus you put it up? Okay, thank you. Just trying to get the technical details. So I'm Shelley Leavitt. I'm with the Institute for Family Development. We are based in Washington State. So it's still morning here, but good afternoon, all of you. And I'm going to try to get actually this, trying to get the slideshow on, which not exactly sure what's not going on. I hope you can all see the slides so far. I'm having some difficulty with my computer, so it may not.
Click the little button at the bottom, in the bottom right-hand corner, next to the plus and minus sign to zoom in and out of the screen. It looks like a little presenting button.
See, this is how I learn, because I just kind of like try it myself, and then somebody gives me some feedback.
That one, yep.
Oh, thank you. See, I've never noticed that before, and I've only used these, for many years. Will people have will they be able to get a copy of these? Because I'm going to be going through it kind of fairly quickly.
Absolutely, it'll be on the Virginia Family First website.
Perfect. So as I said, I am with the Institute for Family Development. We are the parent agency of the Homebuilders program. And so what I'm going to be talking about, rather quickly, is what is Homebuilders, kind of defining the model, and talk about some of the way that we begin with states or programs, the standards, and hopefully if you have questions, feel free to, if you want to wait till the end, or I'm happy to take them during the presentation. So I'm sure many of you are familiar with intensive home-based services. Many states have been providing these really since the late 80s, early 90s. And Homebuilders is considered an intensive in-home crisis intervention, family treatment service. And the program is designed to keep children and families safe, to prevent the unnecessary out-of-home placement of children, and that is placement into, could be foster care, residential, psychiatric placements, juvenile facilities. The model's also been used quite a bit to reunify children and families. Homebuilders is really built on what we call a cognitive, behavioral, and skills-based framework, meaning that we focus on, we have a kind of a headset and a framework of skill building and helping parents, children, teens, the family members we're working with, other caregivers, utilize cognitive and behavioral, research-based cognitive and behavioral interventions and strategies throughout the time we're working with them, and to be able to help them learn other ways of coping, handling situations so children can remain safely at home. Homebuilders really is built on, it began in 1974. It began development in 1974. There's been kind of changes, modifications over the years, but it's really built on a philosophy that it's best for children to be raised in their own families whenever possible, and families being kind of a broad definition of families. And this is really fundamental to what we do, because it is, we have a very strong perspective around families, communities, and also, of course, safety. And I'll talk a little bit more about safety. So the model has been used for, we're now like over 40 years, but has been used for placement prevention, which is probably the primary referrals to Homebuilders. Second is reunification, as I said, to be able to safely return children home. And then in some states, it's being used for adoption and foster care stabilization. So in my state, Washington State, where we have had kind of serious concerns about movement of children in different foster placements, we've used Homebuilders for many years to try to stabilize and prevent adoption disruption, foster care disruption. When we talk about the model, we talk about kind of three aspects of it. And this diagram is really, you could use it for any program model that you're thinking about. And on the one side is program structure, and that we define that in terms of kind of what we call structural components. We have 20 standards for home builders, and about half of them are what we call structural standards. Length of time, so duration of the service, the caseload size, where the services occur, number of hours, et cetera. Program structure standards are the easiest really to measure because many of them are quantitative, and we have a pretty robust data system that can measure these. On the other side are the intervention activities. And what that means is what we actually are doing with things. When we get in the home, how we engage, how we develop relationships, the assessment process, the assessment tools that we use, the skills and intervention strategies that we teach. And those are much more complicated to measure. And so we have kind of a number of ways to do that. And then the base for all of this are the values and beliefs that we have kind of articulated over the years. And they're really, again, fundamental to what we do because they guide our strategies and they guide the interventions. So actually one of our standards is called values-based orientation. And so the standard reads, I mean, that we have a definition of the standard and then lots of aspects to the standard as well as kind of how the standard is measured. But the model is really based on a clearly articulated set of values and beliefs. And as I said, they've guided program design, and they also guide what we do with families, our behavior. And that's what's really important. And I'm not going to go through all of these. Some of these are probably very similar to what you may see as the values and beliefs having to do with working with families or home-based services. We started developing these again in the late 70s. And the first one, of course, is what I already said, that it's best for children to be raised by their own families whenever possible. And then the next one is equally important, and that is safety is our highest priority. Families referred to home builders are typically probably some of the most high-risk families in child welfare or other systems because they're at the door of placement. And we have a very kind of rigorous process for the referral to be able to assess whether or not the referent is serious about placing the child or children. And so much of what we do early on and throughout focuses on safety and trying to structure for safety, trying to ensure safety, trying to promote safety. The next value and belief is something that really the design of home builders was based on when it started in the mid 70s and as it's continued all these years. And that we have a belief that reducing barriers improves families' outcome. And the reason I'm saying these are beliefs is, there's some data to support many of these, and there may not be data to support others. And whether or not it's, we have the data, what we find is by having these values and beliefs, it really helps us to be able to work with sometimes very challenging situations. But Homebuilders was designed in the mid 70s. It began design with the idea of trying to kind of throw out, reduce, decrease, get rid of as many barriers to services as possible. And I know that some of you probably can't remember the 70s. Probably some of you weren't around. Some of you might have been infants, but it was quite a new idea to be able to go into families' home and bring a counselor, have a counselor in families' home, especially in an intensive way. And now we know that home-based services, many of the EBPs are in home, and there's many other home-based services. But at that time, it was basically you had the option of going to mental health centers or other agency-based services. So the structural components of home builders were designed to reduce these barriers, meaning making it easier for family members to both access and be involved in the service, and hopefully to be able to benefit from many of the evidence-based strategies that many of the EBPs actually use. Parents, family members are our colleagues, partners, meaning that we work very closely with them, help them work on goals that they're going to continue, and use strategies and skills that they will continue long after, hopefully, when we're gone. Just a couple other things I want to say about some of these values and beliefs is that we can't predict what situations are most amenable to change. We've tried over the years. We have data on thousands and thousands of children and families, and you can run them in all different ways, and we don't see kind of characteristics that we're less likely, I mean, especially if it's significantly less likely able to be successful. And so for us, it's really a helpful way, and it's important for us to kind of think about that if we can't tell, which situations with which family problems, with what youth, children, caregivers were most successful with, then we just go in giving it our all. And that's a really important kind of headset. We also have found that it's our job to motivate clients and instill hope. There's many, many reasons why families we work with, especially those in the child welfare system who are not coming into the system, on their own volition, they're not necessarily asking for help, are unmotivated or feeling hopeless. And so in the kind of late 80s, early 90s, we began looking at other motivational strategies, and we've built motivational interviewing into Homebuilders, and been using that for many, many years. We think it's really important to have a belief that all people have the ability to change. That doesn't necessarily mean that all people do change, and that change isn't hard. It's hard for probably all of us. But again, it really helps with our headset and how we do things when we have this belief. I think it goes, I hope it goes without saying that, especially anyone who's working in the child welfare system, where the families, children we work with are quite diverse, although tend to be kind of, if anything, similar in terms of economic, living in low income poverty situations. But part of what we do, and part of, I think, what makes Homebuilders a little more complex, is we really do tailor to the diverse families that we work with. And that means tailoring in terms of how we, what we teach, how we engage, how we interact, what we're doing with families. Finally, because again, I kind of want to go through these pretty quickly, not that we don't think they're all equally important, but one of the important, I think, beliefs that we have is that people are doing the best they can. And what that means is that we all can do, every one of us here can probably do a lot more than we're doing. We can all change, or we can all improve. And the families we work with, often, and again, especially those who come through the child welfare system, but through other public systems, have encounter many, many challenges that some of us are fortunate enough not to encounter. And those, what that means is everything from not just perhaps engaging in what is considered child abuse and neglect, but, as I said, poverty and everything that goes with poverty, which often relates to health, education, housing, substance abuse, mental health, etc. And so having this belief that at this point in time, people are doing the best they can is really also a way to help us feel more hopeful as we're working in really challenging situations. So I mentioned we have a number of standards in the structural components. I'm just giving you some examples. I don't have all the standards. This would be like a 5-hour presentation to go through all those. But the structural standards are designed, again, many of them to minimize barriers to service, to decrease those barriers. And one of the standards is the focus on a specific target population. So I mentioned that Homebuilders really targets those families with children at imminent risk at the door of placement, or again, at the point of reunification, and the situation is really complex or challenging, because for many families, other less intensive, which often equates to less expensive services, are fine for reunification. And but for some families where there's still perhaps some considerable challenges, Homebuilders is being used. What we do in terms of this population is I mentioned that we have a specific referral process, and part of it, the referral process, is a conversation with the referent and trying to kind of dig deep and get down to the point of what they would do if Homebuilders wasn't available. Meaning, would they be filing? Would they be placing the child? Would they be in temporary placement, et cetera? We're very serious about this target population, because unless we have, and of course we know it's not 100%, we know that referents often may say things that they know we like to hear, but unless we're pretty assured that the children would be placed without the service, or they wouldn't be reunified at this time without the service, we're not able to say as perhaps confidently that we're preventing placement. So that's why we focus on that. Another standard is that there's immediate availability in response to the referral. So what that means is that, and this doesn't occur in every state, it depends on the system, but referrals can be accepted 24 hours a day, 7 days a week. But the Homebuilder therapist meets with families as soon as possible within 24 hours of the referral, after the referral is accepted. And services are provided in the natural environment, their homes, community. We work in, if the child's in school and have problems, we will go to schools. We'll be talking to the other systems and collaterals that are involved with the family, having meetings. We may be taking people to the grocery store to not just shop for groceries, but to perhaps learn about how to stretch their limited dollars, and also perhaps to just engage and talk about other concerns. One of the kind of defining characteristics of Homebuilders, and for people who have done intensive in-home services, often these are kind of similar characteristics. So it's intensity and caseload. Typically, and we use the word typically quite a bit because we look for variability. And so, and we have a data system that allows us to kind of look at like how many hours a week and what days of the week do the sessions are scheduled. So typically families are seeing 8 to 10 face-to-face hours a week, but it can vary quite a bit. So it could be 12 hours, 14 hours, 6 hours. Typically there's an average of 38 to 40 face-to-face hours during the 4 to 6 weeks. Average caseload of 2. At some point there's our therapists, our practitioners have a caseload of 1 because they're waiting for another referral, and on rare occasions they might have 3 at a time. As I said, it's a 4 to 6 week intervention. We typically talk about to the family and to the referents as a 4-week intervention, because to go 6 weeks, we actually consider those extensions. And we do have booster sessions that are available up to about 6 months after the service. There's 24-hour availability to clients, and this is something that is an integral part of the model, where the primary therapist, meaning that individual who is working with the family, and then the supervisor is backup, is available for emergencies, for crises 24/7. We have lots of ways to prevent those, hopefully, to structure between visits. So in fact, people typically don't get many kind of late night calls, crisis calls. But it is one that is a fundamental part of the model, because it really, the families, I think, are much more likely to call the person that they know than an on-call service or something. We use a single therapist operating within a team. What that means is that it's an individual therapist model or practitioner model. And I do want to say that by therapist, we're not talking about a licensed therapist necessarily. It's just a term that it is the job title that has been used since the 1970s, when the idea of going into the home was so new. We wanted to make sure that the person was seen as a professional. But in many states, they use term practitioner or specialist or other terms. Supervision and consultation. Supervisors and managers are available 24/7 for consultation with the practitioners. There's weekly team and lots of individual consultation. We have a rather comprehensive and involved what we call site development activity process, which there's a slide later that describes some of that, but it includes initial startup consultation, workshop training throughout the first couple years, individual team consultation, individual consultation with a supervisor, with a home builder consultant. So we have a home builder consultant who is assigned to each team, and they're also responsible in the beginning for what we call fidelity reviews. They do on-site visits and outcome reports. So I wanted to just kind of give you an example of like one of our fidelity measures for a standard. And as I said, again, we have 20 standards, and within each standard, we have fidelity measures. And there are many of the standards have numerous indicators and performance measures, because for many of the standards, you know, it again, especially the ones that are the intervention standards that are not the quantitative measures, we have many different sources of information together to look at fidelity and to see what people are doing. And it's really, you know, I think all EBPs know that it is it's a challenge to measure fidelity. And as I said, the easier measurements are the quantitative. We have a web-based paperwork system that everybody uses. And so it's pretty easy to measure the quantitative. And in fact, the people who are on the system can run their own reports. Everything is really transparent, and they can see how they're doing as they go. So this is a couple of the indicators. There are more for the immediate availability and response to referrals. And so one of the indicators, and when we developed the standards, which began developing in probably the early 90s, and then the fidelity measures, and we continue to revise them based on data, but started implementing them outside of Washington State, where other agencies could use the home builder's name in about 2008. When we're developing, we're asking ourselves, so we have these standards, how do we know they're occurring? And those are what we call our indicators. So immediate availability and response to referrals. One indicator is that the provider agency doesn't have a waiting list. And so when they announce openings, eligible referrals are assigned on that day, usually right away. We have another indicator that the therapist meets within 24 hours of the referral. I had mentioned that. And our performance measure, meaning that you're meeting the fidelity measure, we don't expect perfection for most of these. So the measure is that 75% of the families receive their first face-to-face visit within 24 hours of the referral. 85% of the families receive the initial visit within or by the next day, which means that because we're very we're very concrete and specific about time. So as soon as the supervisor who accepts the referral she puts down the time, and if it is at 2:10 Eastern time, then we expect that the family's seen by 2:10 the next day. If they're seen at 3 o'clock the next day or 6 o'clock the next day because they couldn't get hold of the family or the family works, that's what we mean by no later than the next day. And so that means that there's still about 15% of the families that are seen after that kind of next day. And then we have, other measures, like 95% of those have to have the reason for the referral or for the not seeing them by the next day. And that it's because of the family situation, not the workers. So I wanted to talk about some of the intervention components. So again, we have on one side of that triangle, we have the intervention components and the structural. So a really key component obviously is safety. And there's many aspects to safety. So the definition of the standard is throughout the intervention, the therapist assesses child and family and therapists their own safety, develops safety plans, structures the environment to prevent and reduce harm, uses clinical strategies to promote safety. So that's a really broad, kind of vague, in a way, definition. Some of the fidelity measures. So safety being very important, we have a number of fidelity measures. And so kind of the broad indicator is that family safety is increased. Well, the question to us is, how do we know that? And so there's, again, this is not the only measure, but we use the North Carolina Family Assessment Scale known as the Ncfas. There's a domain on there called Family Safety. And depending on how it's rated, we're able to kind of use the data system to see if there's changes in that domain. That's one way. Another way is that we have a referent feedback survey, and we ask them, how satisfied were you that the therapist adequately addressed safety issues? And so it's a 5-point scale, and we hope that there's an average of 4.0 or higher, which means that they've been adequately addressed. Those are just a couple of the measures, because with safety, this is also something when we do consultation with the team consultation, when we read records and looking at safety plans, and also going out on home visits, we're always looking at safety. Another intervention component is that the services are individually tailored. I mentioned that before. And although we use the same framework, what we do with families may look a little different, because what we're trying to do is tailor everything, including when we schedule appointments, to the family situation, to their needs, to the goals, the reason for referral, what's important to them, their values, their learning styles. They all, families we work with have very unique circumstances. And so a way of doing that is we flexibly schedule sessions with families based on both the family schedule, identified problems, the goals, and the situation. So our staff work a very, very flexible schedule. Daytimes, evenings, weekends, not that they're working every weekend, not that they're working every 8 hours on a weekend, but it's very common. In fact, about 12% of the sessions are on weekends. Engagement and motivation, it's a really important part of what we do, part of what everyone who works with in the human service field probably does. And so we have a lot of strategies for that. This again, we have data in terms of dropout or reason why the cases may close early, what we call premature closures, and that's can be an indication of perhaps lack of engagement or motivation, but could also be because the family moves out of the catchment area. But in terms of what we're actually doing with families, we use a lot of reflective listening, active listening. Reflective listening is a fundamental strategy within motivational interviewing. And as I mentioned, that that motivational interviewing is just built into everything that we do. And then there's all the other types of engagement skills that we're doing that really are kind of at the root of being respectful and the way that we're working with families kind of as colleagues. We do a comprehensive assessment. And as I mentioned, we use the North Carolina Family Assessment Scale as kind of a framework for our assessment, since it's was designed specifically for programs like Homebuilders and was validated on Homebuilders and other similar programs. We kind of have a holistic view of assessment, and it's a very kind of ongoing interactive process in terms of gathering information. The North Carolina Family Assessment Scale, I'm sure some of you are familiar with it, but we use the version 2, which again is the one that was validated on Homebuilders and similar programs. It consists of 5 domains, and within each of those domains, there are a number of subscales that are rated. So the research behind the North Carolina Family Assessment Scale had to do with kind of identifying those areas, those factors, those indicators, and what are related to the reasons for why children are placed. And so under environment it's everything from the habitability of the home to income, food and nutrition, the provision of developmental opportunities, et cetera. Parental capabilities is a huge domain where typically we're going to see kind of more serious problems, because that includes everything from parenting skills, discipline, parental mental health, their physical health, substance use, et cetera. So supervision of children. And as I said, there's family safety and child well-being, which is everything from the health of the children to how they're doing in school, relationship with peers, their cooperation, motivation to stay within the home, especially if it's a kind of reunification or we're working with teens. So going through that really pretty quickly. Another standard has to do with goal setting and treatment planning. And we basically developed 2 to 4 kind of behaviorally specific goals that are related to the reason for referral and focus on skill development and behavior change. Some of those, again, may be related to some concrete needs like housing, basic needs, et cetera. I just wanted to kind of show some of these that look at kind of our early sessions with families. And this may be during the first week. Not that we're not continuing to engage and motivate and assess throughout, but what this shows is that we're doing a lot of things at the same time, which I think, again, is pretty common with many services. So we are engaging and motivating, we're trying to gather information, we're structuring and actually assessing safety. We may be providing or assessing the need for concrete services, such as I mentioned before, like food, clothing, housing, help with utilities, whatever it may be. And some of the skills and the knowledge that we're expecting and we're training our staff or other people who are doing the services, again, reflective listening, key strategy. Motivational interviewing, our observational skills are really, really important in terms of being able to assess everything from family interactions to safety in the home and community. We do behavior analyses, trying to look at triggers, trying to look at consequences. Throughout, we hope people and are trying to promote critical thinking, really thinking about what we're doing, because most of what we're doing in working with families involves decision-making. How do we engage? How long the session should last, et cetera. As I mentioned, we use a cognitive behavioral approach using lots of different cognitive strategies, positive behavior support strategies, behavioral parenting, relapse prevention. And as you can see, I'm going through these pretty quickly, so hopefully you can get a copy if you want to look at it in more detail. Teaching is kind of at the core of what we do, and we have many different strategies. Again, we really try to tailor our teaching strategies to the family, to their learning styles. And we don't have, if somebody, if video, it might be helpful, or YouTube, I shouldn't say video these days, ages me, but we have many, video kinds of presentations we can use, but really what we're focused on practice, how we want to be able to see people utilize skills. This is just it's not an exhaustive list, but common skills that we teach families. We're not teaching them all of these. Again, it has to do with the goals that we're working on. So there's lots of parenting skills. And those of you that are familiar with PCIT and Triple P and other parenting, many of these are what are considered behavioral parenting skills. And then communication skills, problem solving, lots of relapse prevention. We work with lots of families where there's perhaps lapses or substance abuse concerns. We're also teaching skills to children and teens. And sometimes it's through the parent. We're not necessarily meeting individually with a 4-year-old. We're working through the parent because the parent really needs to learn the skills. We're acting as a coach, but we're also meeting individually with teens. We can work very strategically with families in terms of trying to figure out we can work with the whole family, with the couple, with partners, parent, children together. We typically are doing all of the above in terms of kind of what makes the most sense for the goals. So these are just, again, kind of common skills that are taught to children, teens. Again, with teens, lots of relapse prevention, lots of emotion management, emotion regulation skills. So even though we don't say, we don't talk about phases, because we may be teaching skills during the first week. And we use what we call teachable moments, teachable opportunities. But when we're kind of focusing on, which is really day one, behavior change, because we may be doing some safety planning that relates to behavior change right away, we are using, again, we're doing a lot of things at the same time. We're teaching skills. We're using, again, research-based interventions. We're evaluating progress. We're asking the families, how's it going? Does this work? Should we, change gears? Again, providing critical thinking or using critical thinking, providing concrete services, lots of collaboration with other services providers, et cetera, if needed. I mentioned that we do provide concrete services. Typically, the programs are allocated a certain amount of what are considered like flexible funds for each family. It varies in different states. In Washington State, we have an average of $200, and it is an average. We can go higher or lower. $200 per family that the State Department builds in, and in other states, it's as much as $500. Collaboration and advocacy is a big piece of what we do. From day one, we're trying to figure out, are there other resources, services, systems, supports, both informal, meaning it could be family, friends, spiritual communities, other kind of communities families are involved in or could be involved in, as well as formal supports, because many of the families, again, they have high needs, they have many challenges, and there may be other supports that they're already connected to, or ones that we are trying to connect them to both maintain the gains made during the service, but also to perhaps address other concerns that are not as related to keeping children in the home immediately, that other providers can address. At closure, at termination, one of the things that we're doing, although we start this, I'll tell you, like from the very beginning, is we're planning for maintenance. Maintenance of behavior change for anybody. It doesn't matter whether you're going on a diet or wanting to stop eating chocolate is really hard, and it has to be planned. And so from day one, we're trying to have that, in the forefront of our brain, to be able to figure out what might be helpful, and to help the family figure out what might be helpful and what could be utilized to maintain and hopefully continue the progress. We have a formal progress maintenance plan that the family develops with us. But again, it's something that we really start from the beginning. So at closure, we are continuing to use, many of our similar skills, reflective listening throughout. But this is where we're doing, the more formal progress maintenance planning, connecting to resources and supports, although again, that could still occur in week one. We're getting client and referent feedback. Their feedback's really, really important. And some of the questions on the feedback survey are related to our fidelity measures. So we try very hard to encourage a high return rate. And there's a collaborative evaluation of goal attainment. We are looking at and talking to families really throughout the intervention. As I mentioned before, how's it going? Are things getting better? Hopefully things aren't getting worse. So how do we measure what we do? There's many different measures because, it's a pretty complex intervention. So obviously we're looking at placement prevention reunification rates. And we look at that at case closure. So in our data system, there's the outcome, in terms of where the child is or where the children are, because in many families, there are multiple, there's not just one child who's at risk of placement, but it may be all the children in the home or just some of the children. And so we look at closure, and then what we also do, and we're able to get the data from many states, but we do have to get it from the state, is we try to get official placement data after 6 months. And what that means is whether a child has been placed at any point from closure to this 6-month period, which is part of our outcome measures and our standards. We also, in some states, are able to get some data at 12 months. So we're looking at placement prevention as well as reunification, or for those cases that are placement stabilization, has that been achieved? We're looking at changes on the North Carolina Family Assessment Scale. It's a tool that is used. We complete it in the beginning, we complete it at the end. And there's some of the, as I mentioned before, some of the standards, some of the fidelity measures will say something like, if, for instance, in parental capabilities, if that is a domain that needs to change or improve in order to keep a child at home, there's a way in our system that is marked. And so then we're able to look at that particular domain to see if there have been improvements. We have behavior change measures. We look at goal attainment. And so when we're writing our goals, and as I said, we have very specific indicators of goal attainment, and then the worker, the therapist, assesses those at the end. We are also gathering information about, are there any CPS reports, child abuse neglect reports during the intervention. And again, if we could get the post-intervention, that would be great too. And then, as I mentioned, we do a consumer feedback survey and a referent feedback survey. And again, on those, there's certain questions that are related to goal attainment, related to some of our other outcome measures, safety, et cetera. So how do we do all this with new teams? It's quite a process. So what we call our kind of site development. And when we work with organizations, and it could be with a state that is planning to start a number of new teams, it could be individual agencies, provider agencies that are starting. We have, again, a number of activities because our whole focus on working with teams and states is to hopefully help, obviously, the programs to be successful, to be effective, to achieve good outcomes, and for our role as the consultants to have that role decrease over time. We continue with programs in some capacity forever, but what we're hoping is that we are able to decrease our time. And so in the beginning, we have a lot of technical assistance that we provide to the state or the county, whatever jurisdiction, if they're contracting with us, or the provider agency. And one of the things that I know is probably quite different than some of the other EBPs is that in the beginning, when a provider agency has been identified, and there's a lot of technical assistance in terms of making sure that even the agency's policies and procedures are congruent, meaning people can be available 24/7, that they can work a flexible schedule, et cetera, that you don't have a waiting list for this particular service. But we're also involved in the staff selection. And I know that that probably might seem a little different and a little intrusive. But what we have but the reason we're involved is because there is incredible importance in terms of the process that we use and the site development process. It's incredibly important to keep staff and to keep them as long as you can, and especially the supervisor, who's the key really to the program. And there's a job fit with this type of service, and probably with many in-home services. Not everybody nowadays wants to do in-home service, and probably in Virginia, like Washington State and many states around the country, you're having a difficult time finding staff. But the job fit is really important because of the flexible scheduling. And it's just not a job for everyone. And so we have hiring interview questions, and there's actually like role play that we require that all the agencies use, in addition to whatever your other hiring process is. And in the beginning, we're doing it with you, or we're doing it in the provider agencies involved. We can't say, you can't hire somebody. We don't have veto power. It's your organization, your human, your HR policies, but we can give, suggestions and advice. And then what we do is we basically teach you how to do that yourself. And so that we can, decrease our time and kind of exit that piece. We're working hopefully with the referents in terms of education, helping you identify and kind of hopefully pave those referral pathways so you get the right referrals, because in the beginning, you often get inappropriate referrals where either the children really aren't going to be placed, or there's kind of many reasons. And then there's initial training and ongoing, it's actually ongoing and initial training and consultation with a home builder consultant. And in the beginning, this is where I should say, I have this down below, but we have what we consider like a scaffolding approach of helping programs develop. And what that means is that we hopefully have a very strong scaffold, like, when you're building a tall building, that is strong, and that hopefully nobody, falls off or we don't lose any of the parts. And then over time, as through training for consultation with the home builders consultant, we're removing pieces of that scaffolding. And so at some point after, the first year, second year, third year, fourth year, our consultant is involved monthly in team consultation, have a few hours of consultation. But the supervisor, again, who's that key person, then really takes over a lot of what our consultant does in terms of even running and writing the fidelity reviews with, again, kind of our oversight. But it's this hands-on, and we have a very hands-on approach, is meant to hopefully strengthen to develop, to strengthen, to hopefully ensure success of the program, and then help us back out with still some oversight, but not as much kind of hands-on involvement. So I know that, and I haven't even asked if there's questions because, and I have a couple more slides so I can answer those. But I wanted to show you, this is actually some of our latest data. And the data here are from a number of different states. And this is placement data at 6 months. So as I mentioned before, that it's easy for us to get placement data at closure. And I'd say somewhere between 85 to 90 or so % of the kids are remain in home at closure. But it's harder to get the data at 6 months. And so we work with states, we send them the information about which families have reached that 6-month mark. They then send us the official data, and we have great data because it says, both in terms of probably the quality of the data, but we also know what types of placements are occurring, whether it's foster care, residential, juvenile facilities, mental health facilities, et cetera. So again, this is a number of different states, and it was almost or a little over 1,200 families served over the past few years in a few different states. And so you can see that most of the families, the children were not placed during that 6-month period. And it shows kind of the different placement prevention. You see again, why that bar graph is so high is that most of the families refer to for placement prevention. The next highest is for reunification. And then there's some for placement stabilization. This graph shows the by children, because there are, in many families, as I mentioned before, there are a number of children in each family that are at the door of placement that are the targeted children. And so these are data on nearly 2,500 children, or it's actually over 2,500 for all of the different services. And so again, you can see the placement rate's about 82% for these. So you are all the first people, besides the people who put this together, to see these data. So questions?
Thank you, Shelley. There was a question emailed in. Is the Homebuilders model open to adapting their model to their sites? For example, using the CANS data instead of the Ncfas for the indicators?
That's a very interesting question. No, they do have to use the North Carolina Family Assessment Scale. If they use the CANS, they could do that in addition. But the one of the things to remember, and we're very familiar with the CANS, it's used in many of the programs in Washington State, is that the North Carolina Family Assessment Scale is really the only tool that is validated for programs like Homebuilders. And so that's really important, because what is meant by that is that the researchers behind it, the developers and researchers behind it, have done validation studies basically showing that changes on the Ncfas are related to other outcomes in terms of prevention of placement, reduced CPS reports, et cetera, and where the CANS is not.
And second question, can therapists have other cases outside of Homebuilders?
Another good question. No, they can't. Unless, so here's there's always like these caveats. If somebody is half-time Homebuilders and they have one family at a time, then they could do probably some other services, as long as, so this is where the big caveat is, as long as they are available to their Homebuilder family, and are able to do that flexible schedule. So there are some programs that, for instance, in some teams where they have a half-time person, and that other half-time person does probably equally flexible service. But if they, for instance, worked in a clinic to do outpatient Tuesday and Thursday, 4 hours Tuesday and Thursday, that really doesn't allow them to have the flexibility to have a home builder. The training is pretty, there's 10 days of training the first year. There's additional for everyone. Well, I should say there's probably 12 days because we have the data system and everything else. And then there's more training the second year. So it's a pretty intensive, expensive process to train someone. So it's really helpful to have full-time people rather than part-time people. But depending on the need in the area, there may not be as a need for too many full, like maybe you have 2.5 people to meet the need.
And what do you recommend for reimbursement rates?
Oh, wonderful question. So I recommend high reimbursement rates, and I'm sure everybody's shaking their head yes. And I'll tell you that there is a very nifty tool that Chapin Hall, University of Chicago, has developed for for many, I think it's about 20 of the EBPs. And if you put in your salaries, so in terms of reimbursement, as providers know, the greatest cost to all of these services is personnel cost, your staffing costs, and that will vary across states. So it's really hard for me to know, what, and I assume even in Virginia that there's some locations that you have to pay more, and some the going rate for salaries might be different. So this tool that Chapin Hall has developed, you put in what your salaries perhaps in your area are, or what you need for supervisor, for therapist. We also have a program manager component and support staff, and it can calculate. And so it's really hard to know. And I would say that with the exception of a couple states, I do know that the reimbursement rate is typically too low, because people are having, and especially the last couple of years, having an incredible difficulty finding staff. And so you would have to really look at, and there's a range, I'd say, from about $6,000 a family to maybe $8,000 or $9,000 a family. Higher in Hawaii. The cost of living is much higher there. But if anybody wants to, I can share with you, like, even just our template for how we budget. In Washington State, this is not the reimbursement, but it probably should be around something like $7,200 to $7,500 a family.
That's so helpful. Thank you so much, Shelley. This was a really good presentation, a lot of information, and we're just so lucky to have all these slides afterwards for people to be able to look at and consistently go back to. Is there anything else that you would like to say before we end the entire series?
Well, thank you for inviting me. If people have questions about the model, about the program, how to start up the training, et cetera, I know I kind of went through this all pretty quickly. Please feel free. You have my email address. One of the things I should say is there's a couple things that I didn't say, that these are common questions that I'm asked. One is, how does certification work? And the answer is, we don't certify teams. We haven't figured that out. It's quite complicated because there's usually changes in staff over time, unfortunately. But the supervisor, they go through what we call a level system. And that's why I said that they're this key person. And there's 4 levels that are based on kind of how they do on various aspects of the model. And once they're at level 4, that's where the end of kind of mid-level 3 and level 4, that's where we're backing out. The other question often has to do with the qualifications for staff. And in our standards, it says for the practitioner position, a bachelor's in a related field with 2 years experience is the minimum qualification. I will say that that is, there'd be kind of a rare person who would probably come in and with that limited experience. We do prefer a master's degree, and that's where, again, when you're looking at the cost of programs, although a bachelor's degree with more related experience can be, you know, sufficient. For the supervisor does have to have a master's. And again, we don't require licensure, but, you know, from like state licensure, but your state might. So those are a couple kind of common questions. But thank you all. Good luck. Good luck with all the EBP implementation. It's an exciting time.
It is. And I think that's it. Thank you all so much for joining.